Hello, my name is George Mexicano, and I'm a professor of medicine in the Division of Infectious Diseases at Oregon Health and Science University. Today, it's my pleasure to give you an update on immunizations. What I'd like to do is first frame the benefit of immunizations so we keep that in mind throughout the presentation. This is data from the Centers for Disease Control and Prevention, the CDC, and it shows that for children born between 1994 and 2016, that vaccines had a tremendous benefit. For example, they prevented 381 million illnesses, almost 25 million hospitalizations, and 855,000 deaths in the lifetime of those children. So vaccines, I think, are very, very important, and I think all of us have a responsibility as essentially acting public health officers to improve the vaccination rates. And I'll talk more about that at the very end of the talk. The other thing I wanted to make sure to discuss and emphasize before we get into the nuts and bolts of my presentation is that the CDC has tremendous resources to help clinicians provide great preventive care to their patients. And so much of the content of this presentation comes from the CDC. And you can see the web page at the top of this slide if you want to look at the vaccine schedules as well as other information. In addition, there's now an app for your smartphone that you can download, which provides information at the point of care. So without further ado, let's start talking about specific vaccines. This is a beautiful photograph of the influenza virus, which is an envelope virus. Influenza causes a tremendous toll throughout the world. And last year, as you may remember, in the 2017 to 2018 winter, the U.S. was hit particularly hard. What you're looking at here in the red line with the triangles is the burden of influenza-like illness in the surveillance network used by the CDC. And the point of this slide is twofold. One is that last year was a heavier flu season compared to prior years, which are shown in the different colors. But in addition, it shows that the burden begins in November and December, typically, and then peaks in late January and early February, and then declines into early April and late March. But you can see that there is variation. So, for example, in 2009 and 2010, the influenza season was actually quite early. And in 2015, it was actually quite late. And so there is this window, if you will, that's classic for influenza, but it can be early or late, and sometimes both. So what is the burden of influenza in the United States? Well, every year, seasonal flu actually causes tremendous amount of morbidity and mortality. As you can see by this pyramid, there's somewhere between 12 and 56,000 deaths every year in the U.S. from influenza, and hundreds of thousands of hospital stays. And the number of cases ranges from 9 million to 36 million, depending on the particular season, the virulence of that particular circulating flu virus, and of course, how well the match is with regards to the vaccine. You may recall that the vaccine is updated every year because the influenza virus is notorious for drifting, and that means genetically modifying itself. And so that every year there typically are some changes in the flu virus, which then makes we're always trying to catch up and predict which strains are going to be circulating. Now, influenza vaccination is misunderstood by many people. And when I talk to patients, I actually don't say to them that this vaccine has a high likelihood of preventing influenza. What I tell them is that if you get influenza, then the severity of the illness is likely to be far less than if you weren't vaccinated. And this kind of perspective is supported by evidence as shown in this slide. So this happens to be influenza vaccination efficacy in long-term care facilities in the U.S. and it shows in 2 different studies that the efficacy to prevent influenza-like illness and respiratory illness was actually quite low, only 23 to 56%. But if you look at the more severe issues regarding influenza, pneumonia, hospitalization, and death, you see that the efficacy actually rises. So the paradox here is that the influenza vaccine is actually a very good vaccine for severe illness, not a great vaccine for simple influenza-like illness. And I think that's misunderstood by a lot of people. And so it helps. You may think about the words you use when you're advising your patients, especially those who are reluctant to get vaccinated. This kind of data and this kind of framing, I think, helps, especially in vulnerable populations, especially the elderly. Well, the good news is that we have a good supply of influenza, and it looks like this year there's a good match between the circulating strains and the vaccine. Time will tell if that's true, but it certainly looks that way from the preliminary data. So we used to also harp about the timing of getting influenza vaccination. Specifically, I used to recommend in North America to give the vaccine between Halloween and Thanksgiving. That was easy to remember, and it helped with the timing that I showed earlier. However, what emerged and what we've realized is that we lost a lot of opportunity to vaccinate both before that time and after that time. In other words, the window between Halloween and Thanksgiving. So the point of all this is that is shown in the first bullet, that seasonal influenza vaccination should be given as soon as your clinic, your outpatient system, actually acquires the vaccine. And so that could be as early as Labor Day, and it could be as late as New Year's. Even into January, I would still vaccinate people because of the importance of the vaccine in preventing morbidity and mortality. So the point is, whenever you get the vaccine, start giving it out to people. There's no true magical window anymore. The other thing that's changed recently is that now it's a universal vaccine essentially across all ages. So everyone 6 months of age or older should be immunized with the flu vaccine. If you're vaccinating a child for the first time between 6 months and 8 years, they receive 2 doses 4 weeks apart. Everybody else gets a single dose of the vaccine. And although the trivalent injection is the most commonly used vaccine, there are other formulations, and there are 3 newer formulations that you may not know about. There's an intradermal formulation for adults. There's a high dose formulation for those who are 65 years of age and older. And there's even a recombinant vaccine that's been developed as well. All of these have equal efficacy. So I usually just give the standard vaccine that's available to everyone above age 6 months. Now, the other issue, of course, is egg allergies. So during the formulation for the vaccine, there are potential compounds in the vaccine that come from eggs, and so the package insert will talk about egg allergies and things like that. But the truth is that many people that have, quote, an egg allergy can actually be safely given the vaccine. And so I like this algorithm from the CDC. And the first question you ask a patient is not whether they are allergic to eggs. Rather, what you ask them is, can you eat a lightly cooked egg, in other words, a scrambled egg, and have no problems? And if the answer is, yep, I can do that, then you can just give them the routine vaccine without any precautions. If they say that they do get hives, then what you can do is you can still give them the vaccine, but the recommendation is to observe them in the clinic for about 30 minutes after the vaccine is given. If they have a more severe reaction, then you might want to consider a referral to an allergist. But the point of this slide is that many people who say they have an egg allergy can actually be given the vaccine and given it safely. Now I'm switching gears to the next vaccine that I want to talk about, and that is the vaccine to prevent pertussis or whooping cough. So we had a particularly difficult year in terms of the epidemiology for pertussis 6 years ago in 2012. In that year, there were almost 50,000 cases and 20 deaths. And it was the largest number of cases we had seen in the U.S. Since 1955. On a worldwide basis, it's still a major problem with 24 million cases and upwards of 150,000 deaths across the globe in a given year. And so the point is that pertussis is still around, and there's a larger reservoir that can bring it back very quickly. And in this age of international travel, literally it's one plane ride away. So we need to be vigilant. And this slide just shows that 2012 was the worst year we've had for a long time. It's dropped since then, but it's still, again, lurking in the background, waiting to reemerge as a problem. So typically we don't give the acellular pertussis vaccine by itself. Rather, we bundle it with tetanus and diphtheria. And so when it's just tetanus and diphtheria, it's TD. When it includes acellular pertussis, it's called Tdap. So here's the current recommendation. If people who have not received the Tdap, or if we just don't know what their vaccine status is, should receive a single dose of Tdap followed by tetanus diphtheria boosters every 10 years. And importantly, Tdap can be administered regardless of interval since the most recent tetanus or diphtheria containing vaccine. In other words, if someone's had a tetanus booster, but it wasn't acellular pertussis, you can go ahead and say, well, we want to give you a vaccine that it will be efficacious against pertussis, and it acts as a tetanus booster, and you don't have to wait 10 years. So what's the recommendation? You administer one dose of this, and importantly, pregnant women actually get this every single time they are pregnant. So with each pregnancy, preferably in the third trimester, they should get the vaccine, and that's regardless of the interval prior to their last TD or Tdap. In other words, if there was a person who became pregnant at age 23 and received a Tdap, and then they got pregnant again at age 25, they would receive a second Tdap. That's just 2 years later. And the reason for that is because we know now that young adults who are the reservoir for the organism, and if they're taking care of infants, then they can pass it on to the infants, and that can be where there can be major problems with morbidity and mortalities in infants who will not be protected early on in their life. So the idea here is to always protect mom with regards to the children. The other issue here is that we now know that not just young adults, but also older teens, they act as reservoirs. And so now there's a universal recommendation to administer one dose for all adolescents in their preteen years. So the next organism that we're going to be talking about with regards to prevention is Streptococcus pneumoniae, which is shown here. Gram-positive diplococci, often lancet-shaped. So this organism, as all of you know, is a major pathogen that causes many, many diseases. It's the #1 cause of community-acquired pneumonia, and depending on the study, it's typically between 10 and 18% of cases are attributed to that particular organism. And you can see that it still causes mortality, about 5%. That there's a reason that it was called, the old man or old woman's friend, because of this mortality number. It also is a major cause of acute otitis media, as well as sinusitis. And if it's invasive pneumococcal disease, you can get bacteremia and, of course, meningitis. So both common and severe illnesses caused by this organism. And this organism has over 80 strains, and that's part of the issue with regards to vaccination coverage. And we'll get into that in just a minute. So there are many different groups who are at higher risk of getting invasive pneumococcal disease, and this is shown on the slide that's being projected. This includes, of course, things like chronic lung disease, including asthma, chronic cardiovascular disease, such as heart failure and cardiomyopathy, diabetes, chronic liver disease, including hepatitis C, people with cirrhosis who are diagnosed with chronic alcoholism if they don't have a functioning or anatomical spleen, if they're immunocompromised, and those conditions include both chronic renal failure and nephrotic syndrome, cochlear implants and CSF leaks, residents of facilities such as nursing homes and long-term care centers, and then finally, all cigarette smokers are considered at risk for invasive disease. So lots of people are at risk. Well, the story of pneumococcal vaccination goes back into the 70s, and there have been essentially 4 major products. First, a 14-valent polysaccharide product, followed in 1983 by the currently licensed 23-valent polysaccharide vaccine. Most of you know that as the Pneumovax, or PPSV23. Then in 2000, a protein conjugate vaccine was released that was effective against 7 strains. So that's technically called PCV7. Most of you know that as Prevnar 7. And then in 2010, Prevnar 13, because it had 13 valences, again, a protein conjugate vaccine. So I want you to just look at the second and fourth bullets for a second and note the numbers here. So the idea here is that the Pneumovax, PPSV23, is active against more strains than Prevnar 13, PCV13. So the benefit of the larger number is more strains. The benefit of the protein conjugate vaccine is it's a better vaccine in terms of the immune response that's triggered by the vaccine. And so there's basically a collision, if you will, between more strains being covered with Pneumovax and a better vaccine take with Prevnar. And because of that issue, both vaccines are recommended, and we'll again show that in detail in just a minute. The first thing I want to show, though, is how good the protein conjugate vaccine strains really are. What you're seeing here is rates of invasive pneumococcal disease in the younger population, children less than 5 years of age, back in the late 90s and early 2000s. And you could see the yellow line here is the overall rate. The white line with the diamonds shows the rate for people that were vaccinated, children that were vaccinated with Prevnar 7, and the green triangles were the disease incidence for the strains not covered by that vaccine. And you could see that the rates plummeted. But if you look at the late 2000s, you can see that towards the end, the non-vaccine strains essentially caused the large majority of invasive disease in children. And so basically, we swapped out the strains that were not covered by the vaccine for the strains that were covered by the vaccine. The good news is that the rates plummeted. The bad news is not all the strains were covered. The other part that was amazing about this story was that not only was there a benefit in the children who were getting the vaccine, it turns out that their grandparents and other older folks actually benefited as well. And so you can see here, the black circles are people who are 85 years of age and older, and the black diamonds are persons between 75 and 84 years of age. And you could see both of those populations benefited from the vaccine that was given in children. In other words, if you give the kids Prevnar 7 back in 2000 and 2001, then you actually decreased invasive pneumococcal disease both in them, the vaccine recipients, as well as in other populations, particularly elderly. So that's another way to talk to patients about this is you're vaccinating children to help the elderly as well as the young people. Well, I mentioned that there were many strains or serotypes, and these are the strains at the top of the slide that are covered by Prevnar 7, protein conjugate vaccine number 7. And you could see that the vast majority of bacteremia and the vast majority of meningitis cases are caused by vaccine strains. But there is a small but significant number of cases that are due to non-vaccine strains. And so this was the reason that the vaccine manufacturers wanted to basically expand the number of strains that were covered in a vaccine product. It was because the blue wasn't completely 100%. In addition, what happened was that some strains of Streptococcus pneumoniae were becoming antibiotic resistant, particularly to penicillin. And so what emerged was that strain 19A, as shown on the right side of the slide, started to cause more invasive disease, and it started to be emerge as a more antimicrobial resistant pathogen. And I'm going to go back a slide. You'll note that 19A was not covered in Prevnar 7. And so that was the other reason to expand the number of strains was because of the issue of emerging resistance to penicillin. So PCV13 or Prevnar 13 included 19A, and the trials showed that the efficacy was just as good as PCV7, both in terms of clinical disease as well as functional antibody level. And the safety profile was similar to the earlier vaccine. So it was first approved for children and adolescents in 2010, and then a few years later approved in adults. And so that's the protein conjugate vaccine that is now widely used throughout the world. So how do we give these vaccines? So for children, healthy kids should receive PCV13 4 doses at 2, 4, and 6 months with a booster basically between 12 and 15 months. If you have started with 7, you just have to complete the series with 13. You don't have to restart the series; you just complete it. If you have an older child who received the complete series, then you have to just do a single supplemental dose of 13. If you have a high-risk child, for example, someone without a spleen, then what you want to do is you want to give both Prevnar 7, PCV7, followed by 13. If you only have PCV7 in a high-risk patient, you should first give PCV13 and then followed by the Pneumovax PPSV23 8 weeks later. This slide shows the percentage of invasive disease now in adult populations. And so the light blue are the strains that are covered by Prevnar 7, this middle color blue by 13, and then the dark blue by the Pneumovax or PPSV23. And this shows basically displays in a different way the story I already said, which is that that the polysaccharide vaccine covers more strains than the protein conjugate vaccine, and there's still the white space above the bars is that there are still strains that are uncovered, and so the quest for expanding the vaccine products continues. So what are the recommendations for adults? If you have an adult patient who's 19 years of age or older with specific conditions that essentially make their immune system not work well, and who have never received vaccination with either 13 or the Pneumovax, what you should do is first give 13, followed by 23 8 weeks later. What are the conditions? These are patients who are immunocompromised, HIV, leukemia, things like that, but also patients with chronic renal failure and nephrotic syndrome. The other group that is at high risk includes people without spleens, and then people who have cochlear implants or who have spinal fluid leaks. So this group gets 2 vaccines, first the conjugate vaccine, and then 8 weeks later the polysaccharide vaccine. Now in adults, it gets a little bit more complicated. So if they're not severely compromised, such as the conditions on the prior slide, but they're still at risk, what we recommend is PPSV23. Again, that's the Pneumovax. If you have these conditions, lung and heart disease, diabetes, liver disease, alcoholism, and people who smoke cigarettes. So these people are at risk of invasive pneumococcal disease, but not at very, very high risk. So they get 1 dose of the Pneumovax before age 65. What happens to them when they get over 65? Well, everybody should get one at that point, at age 65 or older, so if you've never been vaccinated. But what's important here is you first give 13, and then you follow that with the Pneumovax, the polysaccharide vaccine, 1 year later. So not 8 weeks. 8 weeks is for the more at-risk people. For older adults, what you want to do is wait 1 year before giving the second vaccine. If they previously received the polysaccharide vaccine, then you actually reverse it. In other words, so someone who had gotten PPSV23 would get PCV13 12 months later. And the good news is that now most healthcare plans cover both vaccines. That was a problem when 13 was first released, but now even CMS covers both vaccines. So here's a graphical way that is very helpful. You might want to print this or have it handy so that you can use it in your practice. So let me walk you through two different scenarios. The first scenario is these are people who are indicated to receive 1 dose of the Pneumovax, the polysaccharide vaccine, as an adult. And who are these people? These are people with these conditions: chronic heart and lung disease, diabetes, alcoholism, and chronic liver disease, as well as cigarette smokers. So let's say someone's new to your practice. They were diagnosed with diabetes. They've never been vaccinated. You would give them the polysaccharide vaccine, right? And then you would wait until they were age 65. And at age 65, then you would give them a dose of 13. And because it had been so long since they had gotten their initial polysaccharide vaccine, you would then give them a booster of the polysaccharide vaccine, but 1 year following 13. So let me repeat that again. Let's say you have someone with diabetes who's 25. They get 1 dose of Pneumovax. When they turn 65, they get 1 dose of 13. And when they get turned 66, they would get a booster of the Pneumovax. So that's how that would work for these conditions. In contrast, if you had somebody with more compromised immune system, such as the condition shown on the bottom left of the slide, so let's say someone who had developed nephrotic syndrome, what would you do there? You would give them 13, even let's say if they were in their 20s, followed by the Pneumovax 8 weeks later, because these are high-risk patients. And then 5 years after that, you would give them a booster of the Pneumovax, right? And then when they turn 65, you would give them a third booster or a third shot. So the bottom line here is that everybody, so far, the data suggests that we do not have to give a second PCV13, a second Prevnar 13 to anybody. Look at the top of the slide and the bottom of the slide. There's only a blue rectangle once. In contrast, the Pneumovax, you do need boosters, but it depends on the conditions of when the timing is for those booster shots. And here's another way of displaying the same kind of data. So you basically look at the different conditions, and then it tells you which vaccine product to give and when. So that's also helpful. Okay, I know that was a little confusing, but the table should help, and please refer back to the slides if you have questions. Now let's switch to another disease that is very problematic in immunocompromised patients as well as in older adults. So that's, of course, Zoster, which is commonly known as shingles. Well, it's a very common disorder. The lifetime risk is about 1 in 3 people in the United States, about 1 million cases every year, and the risk goes up if your immune system gets suppressed, or as we age. In fact, half the cases occur in people who are over 60 years of age. And as all of you know, it's not just the Zoster, which is a reactivation of the varicella zoster virus that's been hiding in the dorsal ganglion of neurons. It's not just the shingles or Zoster that's the problem, of course. The more problematic complication is PHN, or post-herpetic neuralgia, a very painful condition which can last for months. And what is shown in this slide is that the risk increases with age. And so in blue are cases of herpes zoster, in white are cases of post-herpetic neuralgia. And you could see that the burden of illness really occurs in the elderly. So there are now 2 vaccine products. I'm going to first talk a little bit about the older product, and then I'll talk about the newer product in just a minute. So the older product is ZVL, or Zoster Vaccine Live. The brand name is Zostavax. It's a live attenuated vaccine. It's actually the very same strain as the chickenpox vaccine, the varicella vaccine given to children, but it's 14 times more potent. The dosing is much higher, partly because older people who get this vaccine don't mount as vigorous of an immune response to the products in the vaccine. It's given sub-Q in the deltoid region, and how good is it? Well, it decreases zoster by about 50%. It decreases PHN by 67%, and the entire burden of illness, which is severity times duration, is about 60%. So it's a good vaccine. I wouldn't call it a great vaccine, but it's a good vaccine to use. And how do you give it? It's indicated for adults who are 60 years of age or older, regardless of the history of zoster. You can give it to patients with most chronic conditions, and you don't have to worry about a titer or a varicella history. And you can even give it to people who are over 80 years of age. Here are the contraindications. So basically, people who are severely immunocompromised, who are receiving, who are pregnant, who have active untreated TB. Those people you do not want to give this vaccine. The new product is called RZV for recombinant zoster vaccine. So there's not a live vaccine. The brand name is Shingrix. It was approved by the Food and Drug Administration last year in 2017. And just 5 days after the FDA approved it, the Advisory Committee on Immunization Practice at the CDC voted to recommend this vaccine for adults who are older than 50 years of age to prevent shingles and post-herpetic neuralgia. Importantly, the recommendation also said that adults who had previously received the live vaccine should get this vaccine. In other words, this is the preferred vaccine, and if you have a patient who's received the Zostavax in the past, should get Shingrix if they've not received the newer vaccine. So what is this vaccine? It's actually the target, or actually the adjuvant, is a surface glycoprotein E from the varicella zoster virus. And again, it is the preferred vaccine now. The disadvantage is that it requires 2 doses. It's given intramuscularly, and basically you give dose 1, and then 2 to 6 months later give dose 2. So it's a better vaccine. You give it at, I'm going to go back a slide, you give it to people who are 50 or just over 50 years of age and into longer periods, but you do need 2 doses. So these next 2 slides, I just want to give you a word of caution. These slides show data from the company trials. So this is from GlaxoSmithKline. I just want to make sure people know that this is industry data, but I think it's important to share this information with you. So what you're looking at here is patients given placebo versus patients giving the new RZV vaccine. And you could see that the incidence of herpes zoster, HZ, per 1,000 person years was much lower in the vaccine group compared to the placebo group. Even the older population, so patients who were over age 80, the incidence was much lower in the vaccine group compared to the placebo group. So this vaccine does prevent zoster. You may ask, well, what about post-herpetic neuralgia? That's shown on this slide. Again, the incidence for post-herpetic neuralgia is higher in the placebo group compared to the vaccine group, again, even in the older population. So this vaccine does prevent post-herpetic neuralgia, and it does prevent herpes zoster. But I want to go back a slide. You'll see, all right, that it's actually a better vaccine against herpes zoster than it is for postherpetic neuralgia, but it is still efficacious. Okay, now let's switch to to human papillomavirus, or HPV. This is a very common virus, as you can see from this slide. 5.5 million cases. The prevalence, fortunately, is now changing because of vaccination, and it is typically sexually transmitted. So 75% of sexually active adults are infected over their lifetime with this one of the strains of this virus. And even though it quote might become undetectable, the genome is probably still present in epithelial or endothelial cells. In other words, it's probably a lifetime infection, but the risk definitely decreases as you get older in terms of detecting a virus. 400,000 annual office visits, billions of dollars spent. Most of the visible warts caused by these virus strains are from type 6 and 11. Most of the cancers are, particularly cervical cancer, are caused by type 16 and 18. And this slide just shows that the number of physician office visits from genital warts increased over in the last half century over time. Well, the new vaccine has helped with that, and I'll show you. It has helped decrease the burden, particularly for severe disease, and I'll show you that in just a second. But first, what is this vaccine? The human papillomavirus vaccine is a recombinant vaccine that is created in yeast cells, and the target is the L1 protein. It basically assembles a virus-like particle, but it's not a live vaccine and it's not infectious. This is the data I was alluding to, so let me walk you through this. What you're seeing here is the prevalence in women in these private health plans, and what the prevalence was for cervical intraepithelial neoplasia grades 2 and 3. And you have different age groups shown on the slide between 2007 and 2014. And what you see here in the blue is that young adults, age 20 to 24, as well as teens, that the prevalence has decreased. So in the younger populations, cervical intraepithelial neoplasia has definitely decreased, and we believe this is due to the efficacy of the vaccine. What's interesting is that you can see that the older groups have actually risen, and so the question that is still unanswered is how much, at what age should we continue vaccination if someone's not been vaccinated, or initiate vaccination if someone's not been vaccinated in these older populations, and that's a little bit controversial. So here are the recommendations. First for the girls and then for the boys. The top bullet. So 2 doses of either the 9-valent strain or product or the 4-valent product for girls between 11 and 14 years of age, and you basically give 2 doses at 0 and I think it's 2 to 6 months following the initial dose. You have to give 3 doses if they're older. And the same is true for the boys, same thing, right? 2 doses for 11 to 14, 3 doses if they're 15 or older. But here's the difference. In the women, the recommendation goes up to age 26. In the men, the recommendation is up to age 21. If you're immunocompromised, then you should always get 3 doses regardless of the age. But the question that I was alluding to was this, is should these numbers, 26 for girls, 21 for boys, should this actually be increased to a higher number because of these curves that I showed earlier? And I think that over time, as evidence accrues, that we will probably, I would anticipate that we would be vaccinating women who are into their 30s and men into their late 20s or even early 30s as we accrue more data. But currently, these are the recommendations from the CDC. Okay, finally, let me talk about this organism and the importance of vaccination. This is Neisseria meningitidis. This is a gram-negative diplococci inside white cells, a very, very pathogenic organism. So Neisseria meningitidis has two virulence factors, a capsular polysaccharide, and that is what essentially differentiates the different types. So there's at least 13 different types of Neisseria meningitidis. And of course, this is a gram-negative organism, and so it can lead to an endotoxin cascade, which produces sepsis. That can be very, very severe. And of course, it causes meningitis. Leading cause of acute bacterial meningitis in young people, with a 10% fatality rate. It has a very distinguishing feature, which is the rash, and the groups are characteristic groups are found, if you will, with different kinds of outbreaks. So serial group A is associated with outbreaks in sub-Saharan Africa, and serial group B is associated, especially in the U.S., with outbreaks on college campuses. And that's important because of the vaccine products we'll be talking about. So the way I think about this is A is for Africa. B is for books, so for college. So this slide shows the carriage rate, and this is one of the reasons why young adults and older teens carry the burden of this organism for meningitis. And what you're seeing here, just look at the green bars. This is the nasopharyngeal carriage rate for Neisseria meningitidis. And so little kids and older adults, really there's not much carriage. But if you're talking about people in their late teens or early 20s, you can see that somewhere between 20 and 25% of the population is actually a carrier for this. And so what happens is, call them person A that grew up in town A, they might have been exposed and are carrying a particular serotype. Person B in town B has a different serotype, and now they join the military or go to college, and they're together, and then they give each other the strains that they didn't grow, that they were not familiar with, not been exposed to when they were younger, and that's when outbreaks occur. So the bottom line is that lots of young people carrying different strains of this organism, and when you mix the young people together, then they will share the organisms in their nasopharynxes and oropharynxes, and the organism can spread. This is a picture of sub-Saharan Africa, where the notorious meningitis belt occurs. And unfortunately, the slide doesn't show it, but the Saudi Arabia is over here on the right side of this slide, or would be here if it was a full map. And in particular, during the Hajj, which is a Muslim holiday, there's a big pilgrimage there, and so there are large outbreaks in the Arabian Peninsula as well as in sub-Saharan Africa. So this organism, again, causes sepsis, and when you first see the rash, it looks like small vesicles over a red base, but then what happens is you start getting necrosis, and you can get these necrotic plaques. Basically, I shouldn't say plaques, necrotic macules, which then can ulcerate. And if the patient's adrenal glands are affected, you can get what's called purpura fulminans and have very severe, severely affected areas in the skin. Now, this organism, like I said before, has at least 13 different types or strains, and the vaccine products cover different ones. So MenACWY is a 2-dose vaccine product that targets the proteins. It's a protein conjugate vaccine, and it covers 4 strains, A, C, W, and Y. MPSV4 is a polysaccharide vaccine that covers the same 4 strains. And like I said before when I was talking about the pneumovax, the vaccines that are protein conjugates tend to be more efficacious. They produce essentially a better immune response. So the protein conjugate vaccines are considered a better product in general compared to the polysaccharide vaccines. So most people give MenACWY out to their patients. More recently, the vaccine makers have been able to produce 2 vaccines targeting strain B, and as I said in a few slides ago, strain B for books is a strain that causes the outbreaks in colleges. So there is no vaccine that covers 5 strains, and so that's the problem in the U.S. right now. Is we have a good vaccine, MenACWY, that is the one that's given to most young people, and B is starting to emerge as an important vaccine, particularly when there are outbreaks. So how do you give MenACWY? You give the first dose in the preteen years and then a booster at 16. If you start the vaccine series a little bit older, then you give the booster, you delay the booster by a couple years as well. In other words, if the first dose was at 15, you give the second dose at 18 years. If they get to college or to a military base and were never vaccinated, all you need is a single dose for that older population. And if they're high-risk patients, then they would also be given a serogroup B vaccine. So, for example, if someone had a complement deficiency, or if someone did not have a spleen, or had functional asplenia, they would get both vaccines, the B vaccine as well as MenACWY. So my final slides really are a plea for all of us to play an active role in trying to boost vaccination rates across the country and, in fact, the world. This slide basically showed that in the 2012-2013 year or season, that only 45% of the U.S. population got vaccinated for influenza. Many more people could have been protected. Many more people could have had their lives saved or not been hospitalized if the vaccine rate had been higher. So basically, unlike children, which tend to have very high rates of vaccination, adults don't, and that's what's shown on this slide here. So what you're looking at is on many different vaccines, all the different curves and lines, and the point of this is that none of them are anywhere near 90 or 100%. So the great vaccine rates we see primarily because of the school laws in the kids does not propagate into adults. What are we doing the best at? In green is Tdap, and in blue is Streptococcus pneumoniae. So for those two, we're in the 60% for adults. The purple line is flu, so we're getting better, but still, again, in the low 40s. And the burgundy triangle is HPV, particularly in females. So we're getting better for some of these vaccines, Zoster down here, HPV here, but really mostly flat lines for things like flu, pneumococcus, and even influenza. We could do a lot better, and that's the whole point. My plea is that I think we need to be more assertive. We need to be more persuasive when we talk to our patients, and we need to vaccinate more people. Like I alluded to earlier, vaccines are incredibly important, and one of the most important things that we can do for our patients is to advocate and deliver more vaccines. How do we do that from a system perspective? Well, part of the reason why I'm giving this talk is this, right? Improve public and provider awareness of vaccines, their benefits, and how to give them. We also need to strengthen all of our healthcare system's capacity to deliver immunizations. And that was kind of what I was alluding to with influenza. Don't just give it in that sweet spot between Thanksgiving and Halloween. As soon as you get the product, start giving it out. Expand coverage in health insurance programs. Promote immunization rates as a measure of quality. And I would actually go as far as say, and then provide monetary incentives if quality metrics are quality benchmarks are met. Improve surveillance, improve safety reporting, and we always need more vaccine research. So all of these are a multi-pronged approach to improving vaccination coverages in the U.S. So I thank you for your time, and I hope that you found this both interesting and informative. And again, I am pleading with you to be a public health advocate, be a public health officer, and immunize your patients. We have a long way to go before our patients are optimally immunized to prevent serious illness. Thank you very much.